Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health, finance, and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about brain tumors, how they're classified, what causes them, if we know that, and how to make sure you have access to the best treatment options. Tonight our guest is neurosurgeon Marcus Ware. In the second half of our program, we'll be taking your questions live by phone at 504-866-3200. There's the number, 866-3200. And by email. You can email your questions to us at hhquestions@wlae.com. Many of you have already done that. You can send the emails now. We'll ask you to hold off on the phone calls for about 20 minutes or so. Tonight on the program, we welcome neurosurgeon Marcus Ware. He earned his medical degree from Harvard Medical School in Boston, Massachusetts, and obtained a PhD in neurobiology from Harvard. He completed his residency in neurosurgery at the University of California in San Francisco before completing a skull-based fellowship at the University of Arkansas for Medical Sciences. Dr. Ware specializes in the treatment of primary and metastatic brain tumors, as well as being able to provide treatment for a number of issues related to spine disorders. And we are pleased to welcome to the program Dr. Marcus Ware. Not bad for a Mississippi boy.
Thank you very much.
I can say that because you're from Indianola, right?
Right, exactly.
The Mississippi Delta, and I'm from the Mississippi Gulf Coast. So
yeah.
A couple of Mississippi guys sitting here. And not bad taste in clothes, too. We did not arrange the double purple tonight, but we will take it, right?
Maybe there was a sale.
Maybe, maybe there was. Well, doctor, we always begin with one of the toughest questions. What was it that first got you interested in medicine?
Well, interestingly, I'm not one of those people who knew my entire life that I was going to go into medicine. It's a decision that I made in college. I grew up, like you said, in Mississippi, and I really was attracted to the sciences, and went to Tougaloo College in Mississippi, where I majored in chemistry. And while at Tougaloo, I became involved in a number of research projects, became very interested in the biomedical sciences, and at one point thought I was going to be a biomedical scientist of some sort. It was only after doing some research and working with a number of people that I realized that practicing medicine would give me the opportunity to do more than the biomedical research, and that I could still actually satisfy my curiosity as a scientist and treat patients.
In our preliminary discussion, I was asking you, is there someone who influenced your career in medicine? And you said a whole lot of people, and we probably don't have enough time to talk about them all. But one in particular, and I bring him up, Dr. Charlie Wilson, only because he helped bring you to New Orleans, right?
Yes. Excuse me. Dr. Wilson is really genuinely one of my heroes. He is a New Orleans original. He was born in Missouri, but did all of his training in college, medical school, residency here, and then as a junior faculty was here. He's been involved in Tulane and Ochsner for many years. And when the opportunity came for me to move to New Orleans, he was my biggest proponent in doing that and really facilitated that process.
Well, we're glad he invited you, and we're even more glad that you accepted the invitation to be a part of our city. Well, let's begin, Doctor, by talking about brain tumors and how they're classified.
So brain tumors can be classified into two very broad categories. There are metastatic tumors. Those are the tumors that are born outside of the brain and then travel to the brain, and those are the most common, actually. And then there are primary brain tumors, and those are cells that actually come from at least the neurons or support cells in and around the brain.
Very good. And you've got a couple of more images here to take us through as well, right?
Yes, yes.
Okay, so now can there be a brain tumor that is, we hear of cancerous tumors and benign tumors? Can we have a benign brain tumor?
Yes, yes, you can have a benign brain tumor. Okay. So benign tumors are those tumors that where there is excessive growth. Some of them may grow to a certain point and then stop, okay? But the biggest difference between benign tumors and malignant tumors is that for benign tumors, removing those tumors completely will give you a cure, okay? For malignant tumors, there is a higher propensity for those tumors to recur, even if the entire tumor is removed. And so it's for those tumors that you need to give other treatments.
Do we know what causes brain tumors?
So there are a number of tumors that are associated with certain things. So for instance, meningiomas are associated with, there are types of meningiomas that are associated with exposure to radiation therapy. There are types of high-grade gliomas that are related to exposure to radiation therapy. However, most of the tumors that we treat, we don't really know the cause other than there was some mutation in the gene of a particular cell that caused it to grow uncontrollably and to gain certain features.
So we know radiation is a risk, but are there any other risk factors we should know about for brain tumors?
So for the primary brain tumors, the biggest risk is what we had talked about, the radiation therapy. For the metastatic tumors, which make up, like I said, the larger proportion of tumors, it's the same risk factors as what causes the initial disease. So it's the things you already know. It's the smoking, and smoking is the biggest. Asbestos exposure, so on and so forth.
Okay. Well, as we mentioned in the beginning of the program, Dr. Ware specializes in the treatment of metastatic tumors. In these cases, what are some of the available treatment options?
So for metastatic tumors, the treatments that are available include surgery and radiation therapy. Essentially, are the biggest. Chemotherapy is a third option there. Okay. So for the metastatic tumors, surgery actually takes the primary role of cytoreduction, meaning that it removes the bulk of the cells, and it allows essentially the person to function much better, and that's what all the studies show. Okay, that can be followed by either focused radiation therapy or whole brain radiation therapy.
Okay, good. What are some of the major signs and symptoms associated with brain tumors, and would it ever look like a stroke, or is it ever a stroke?
So the symptom that one gets from a brain tumor really depends on where that brain tumor is located. Okay, and so tumors can cause focal dysfunction in the brain, which can lead to weakness, could lead to problems with sensation, and a number of other symptoms that would mimic a stroke. In addition to this, seizures are a major telltale sign. In fact, about 50% of people who have a brain tumor will have a seizure at some point. So anytime an adult has a new onset seizure, one has to really become suspicious for a brain tumor.
Okay, and we've heard of fast-growing tumors, slow-growing tumors. Typically tumors in the brain, fast-growing, slow-growing, or can we characterize them that way?
They can be variable, but the biggest thing that you have to that makes a difference in brain tumors versus other tumors is that the brain is inside the skull, which is essentially a closed box. So you have a fixed volume, okay? So in the instance that someone has a fast-growing brain tumor, you can have dysfunction because of focal irritation of the brain or invasion of the brain nearby. But in addition to that, as that tumor gains mass, okay, it increases the pressure within the head, okay? And will therefore cause headaches in patients initially, but can also lead in alterations in consciousness. So headache is common, okay? But in a patient with a fast-growing brain tumor, headaches are going to be extremely common, okay? With slower-growing tumors, there's a difference there because with a slower-growing tumor, the brain has time to accommodate to it. So for slower-growing tumors, you can have a relatively large tumor with very few symptoms. Those slower-growing tumors are also usually benign, so they don't cause as much irritation, and patients tend to not have the seizures and the headaches that you have when you have the faster-growing tumors.
Okay. There are treatment options, but really there is no cure as we speak, correct?
That is correct. For malignant tumors, there is no cure. For benign tumors, a complete resection in most cases will give you a cure, although those patients should still be followed. Okay.
Now, why wouldn't, layman's question, for malignant tumor, why couldn't you just go in and, just like a benign tumor, remove it? Why couldn't you at least attempt to remove a malignant tumor?
You can, and as I mentioned before, surgery is a possible treatment for a malignant tumor, okay? However, with these malignant tumors, especially the types that are born in the brain, they also have the ability to rapidly divide and spread throughout the brain. So these tumors really exist in two parts. There's a solid component that you can see, and there are cells beyond the margin of what is you see on an MRI, okay, that are there also, okay? That is also true with malignant tumors that come from outside the brain.
Okay, let's talk about diagnosing brain tumors and how that process works.
So the gold standard for diagnosing a brain tumor is an MRI at this point. Okay, so more and more patients are having MRIs and CT scans for different reasons. Okay, so at this point, we still see most patients who have some symptom though that brings them in. So just as you were saying before, you can have problems with a brain tumor that leads you to see your doctor, and then they will get the imaging that would lead to the further workup.
Okay, so MRI, CAT scans?
So MRIs and CAT scans are very similar. MRIs are much more detailed and show soft tissues much better. A CAT scan is usually done as an initial screen when someone presents to an emergency room for a problem, and they want to essentially differentiate whether this is a evolving stroke, or a seizure or whatever problem you're having for some other reason, such as a hemorrhage.
Okay. This is the second program in a row I've asked this question, but it's a fair one. 3D or 4D imaging, would that be helpful to you in diagnosing?
Well, at this point, the MRI is the gold standard, and there are a lot of other information. There are a lot of other things that one can get from an MRI. So, for instance, we can look at an MRI and see the image, a static image, but we also have the ability to look at cerebral blood flow around an area. So we know that tumors, for instance, demand more blood, and so if a tumor is expected, we can actually look to see if there is increased blood flow around that mass. We can also do spectroscopy, and spectroscopy is essentially looking at the different components, the molecules that are in the tissue, and there are certain signatures that you can see for malignant tumors versus stroke versus an infection.
Okay, good. We're visiting with neurologist Dr. Marcus Ware, and tonight we're talking about brain tumors and treatment options for them. Of the curable types of tumors, what are some of the common forms of treatment there?
So for the tumors that can be cured, as I mentioned, surgery is an excellent option. Radiosurgery is another one, or radiation therapy is another one. Of the radiation therapy, radiosurgery is focused radiation therapy, and then there is also whole brain radiation therapy, where essentially the radiation goes to the entire brain.
Okay.
Okay.
So, are there types of tumors or disorders, other types of brain tumors that you treat?
Mm-hmm. So in addition to treating brain tumors, we treat a number of other disorders. We treat a lot of patients who have trigeminal neuralgia, face pain syndromes. There are patients who present with cysts in their brain brains that we treat. So essentially, as a neurosurgeon, even with a subspecialty in tumors, we treat patients who present with any mass that affects the central nervous system. And we use any of the modalities that we mentioned. Some of those modalities can cross over and be used to treat other things. So for instance, radiosurgery can be used to treat facial pain and so on and so forth.
Okay, so let's talk more specifically about radiosurgery and how it differs than more traditional surgical options.
Okay, so with traditional radiation therapy, what one generally receives is radiation to a very large field. And so with that, you're affecting both the tumor and normal tissue, okay? And so that radiation is given in small amounts over regular periods of time, and it takes advantage of the normal tissue's ability to repair itself over the malignant tissue. So radiosurgery works differently. What radiosurgery does is it allows the surgeon and radiation oncologist to focus very small beams of radiation onto a mass, okay? And in doing that, you have very high doses of radiation at the point where you want it on the tumor that you want to ablate, and very low doses in other places. So one can, in 1 to 5 fractions, treat these tumors and essentially destroy the tumor while leaving the rest of the brain unscathed.
Okay, and I think you brought along an algorithm for treatment. Let's take a look at that and explain that to us if you could. Let's look at that now.
Okay. So essentially, what that algorithm looks at is who can receive what treatments and why. So
yeah, I think it's on the next slide here. There it is, Doctor.
Yeah, there it is. So essentially what this does is it says that patients who have this KPS, the KPS is essentially your functional status, whether you're walking and talking and able to essentially live outside of an institution, a hospital or a nursing home or so on and so forth. So essentially what it does is it divides patients into those who are well enough to receive treatment and those who are not. So for patients who have malignant tumors, especially metastases, if they have a very low KPS, they are essentially treated with whole brain radiation therapy, which can be palliative, okay? It can help their symptoms and give them a better quality of life, okay? However, if you have an excellent functional status, if you're able to tolerate treatment, then then essentially you fall into another arm where we then have to look at the number of metastases, okay? So if a person then has just one mass in the brain and that mass is causing dysfunction, then there are a couple of options. One is you can have surgery and remove that mass. In removing that mass, you can obtain your diagnosis, know exactly what it is, and alleviate a lot of the symptoms that are caused by it, okay? Then after that, you can be treated with other forms of treatment, like radiation, okay? But if you have multiple metastases, 1 to 3, then most neurosurgeons aren't comfortable or happy to do 3 neurosurgery procedures on a person for these tumors, and it's not curative. So in those cases, radiosurgery, or focused radiation therapy, has actually been shown to be very useful.
A combination of several things.
A combination of several things. And where patients fall really depends on a lot of things. It depends on their functional status. It depends on the status of their other disease processes. So you have to see the patient go through, make sure they can tolerate the treatments that that you might be interested in giving them. And then last but of course not least, it's the decision of the patient and the family. And so I often tell patients, I am here to let you know what your options are and to take you through this process, okay? But some people are very risk averse, and they say, I'm at a certain age, I don't want anything that's aggressive, okay? Other people say, well, I've lived to this point, I've done very well. If you can alleviate the symptoms by removing this tumor and treat me aggressively, that's what I want. And so a lot of that goes into play.
How often do you get, doctor, what would you do if you were me?
I usually get, what would you do if this were your mother or father? Mm-hmm. And I always tell people, I always treat every patient like their family. Mm-hmm. So New Orleans is a small place, okay? And we're all neighbors, so you have to actually kind of treat people like they are neighbors, because they just might be.
Good point. Well, we'd like to invite you to call us now with any questions you might have about brain tumors, what causes them, and how they're treated. Our phone number is 504-866-3200. That's 504-866-3200. You can call with your questions right now. You can also send us questions by email. And again, many of you have already done that. Our email address is hhquestions@wlae.com. Doctor, in what kinds of cases is chemotherapy the recommended treatment option for brain tumors and other associated tumors? And talk about chemotherapy.
Yeah,
for us,
so chemotherapy is essentially where patients are given a drug of some type that will go in and affect the tumor in some way. Usually it's in a way that damages that tumor so that it can't reproduce, okay? Or it acts on it in some way that encourages it not to reproduce, okay? So in doing this, most of the chemotherapy that we give for brain tumors actually will, in some way, kill that cell which is dividing rapidly and allow cells that are not dividing rapidly to repair themselves, okay? So that's how that works. Unfortunately, for most brain tumors, there are not a huge number of options. So for the primary brain tumors like glioblastoma, we have a few drugs that we can use. But for the vast majority of cases of brain tumors, the metastatic tumors, we don't really have very good chemotherapeutic options. It's an area of active research and something that we're very, very interested in.
And with radiosurgery or radiation, you talked about the single beam or the very tight beam versus the larger one. With chemotherapy, yes, you're hopefully impacting the tumor, but you're also having a negative impact on adjoining healthier cells.
Yeah, that is very true. And then for chemotherapy in the brain, you also have this increased difficulty of dealing with the blood-brain barrier. Okay, so essentially, the chemotherapy that you can give for brain tumors has to be accessible to those tumors. Unfortunately, the blood-brain barrier is essentially a mechanism by which the vessels that are normal to the brain keep certain substances out. And so not all chemotherapy that works in the body will get to the brain and work in the brain. So right now, one very active area of development is looking at drugs that cross into the brain, okay, that are preferentially taken up by brain tumors, okay? And then the silver bullet would be the one that would kill the tumor cells and leave the brain virtually unharmed.
It's not the rosiest picture we've painted tonight, but it's a realistic one. I'm going to ask you to look to the future in a moment. So if I had you back on the program 5 years from now, what would we be talking about? Would we be able to offer more hope? But to give us some perspective, what were we doing 5 years ago? How have things changed in a positive way over the last decade or so? How far have we come? And then how far do we still have to go?
Well, I mean, I think the best answer is that that the progress in the treatment of brain tumors has been relatively slow. I mean, if you look back to when radiation therapy was first employed for the treatment of this tumor, you're talking many decades ago, okay? So radiosurgery was invented, in the 60s, but right now has reached much more prominence in treating these tumors. So the availability of that technology is much better. So where do we think we're going to be in 10 years? I think in 10 years we're going to actually have a lot of additional options compared to what we have now. Okay, so in addition to things like radiosurgery, we will see more laser treatments for tumors. Okay, and that includes that laser treatments involve making small holes in the skull, putting a probe in near the tumor, and then heating that tumor up with the laser to treat it. Okay, that's one option. In terms of chemotherapy, there are a number of drugs that are coming down the pike. In the treatment of malignant melanoma, there are a number of options that are available now. We have some clinical trials going in Oxner for some unique drugs that cross the blood-brain barrier, and in animal models have shown to have extremely good results. We've gone through phase 1 of those trials where we look to see if the drug is safe in humans, and now we're actually doing phase 2, the part of the exploration of a drug where you look to see how well it treats the patients who present with that tumor type. So that's an option. And there are many more things that are coming down the pike. So right now is a very exciting time for people who are interested in the treatment of brain tumors.
All right, we'll talk about the prevention side and optimism there at the end of tonight's program. We're going to take a break. Again, we invite you to call us with your questions. 866-3200 is our number. That's 866-3200. Or send us questions at hhquestions@wlae.com. We'll get to as many of them as possible. We'll be back with your questions in a moment. This is Hello Health on WLAE.
I needed help finding a doctor.
PACE.
I needed help with my medication.
PACE.
I needed help getting around.
The Shirley Landry Benson PACE Center is a place that helps seniors remain in their homes, providing the care they need. If you or a family member are over 55 years old, you may be eligible for benefits offered by PACE. For more information, contact us at 504-835-0006. PACE, caring for those who cared for us.
You're watching WLAE, New Orleans Public Television. Find us on Facebook and follow us on Twitter.
Welcome back to Hello Health on WLAE. I'm Tom Bagwell. Tonight we're talking about brain tumors, diagnosing them and treating them with neurosurgeon Dr. Marcus Ware. And now we go to your questions. Let's start on line 3 in Destrehan where Judy is holding. Judy, you're on Hello Health with Dr. Ware.
Hi. Yes, I do have a question. So I heard Dr. Ware mention that something about trigeminal neuralgia. And so my mom was diagnosed many years ago with this face pain, and she suffers terribly. And she went to the dentist, and she had some teeth removed. And so I was wondering if anything that Dr. Ware's been talking about can help something like this with this face pain, this terrible, terrible pain that my mom has.
Doctor? Thank you, Judy.
That's a very good question. Trigeminal neuralgia is a disease process from which many people suffer. It is a face pain syndrome that's caused by irritation of the nerve that subserves sensation to the face. Okay, that nerve also supplies sensation to the teeth and the eyes, and so often patients will present with what they believe is a toothache. Okay, this pain is horrible, and it is described as some of the worst pain that anyone can have.
So on the little chart they give you in the hospital or the doctor's office, 0 to 10, with the smiley face is the 0. This is in the 8 to 10 range.
It's in the 8 to 10 range, and it's unrelenting, and it actually keeps some people from being functional. There are people with such bad pain until when they are in crisis, they can't leave their home. Now, the primary treatment for this is medicines.
Do we know what causes it before we get to the treatment?
We do. So this irritation is caused by an artery that happens to actually cross over the nerve, and with each beat of the heart, it actually hits the nerve. That sets up abnormal circuitry within the nerve, which causes it to fire inappropriately. Okay, so the traditional treatment for this is medicines, and it's the type of medicines that we give for seizures because it changes the firing of that nerve. Okay, now when that doesn't work, there are two treatments. One treatment is actually called a microvascular decompression, and with microvascular decompression, it is a surgery whereby the neurosurgeon would bring the patient into the hospital, go into where that nerve is, which is in the back of the head, perform a small craniotomy, find that artery pushing on that nerve, and separate the two. Okay? Now, as you might imagine, for someone who's of age, that may not be a great option. Okay? The second option for them is this procedure called radiosurgery. And with radiosurgery, it's a non-invasive procedure whereby we bring the patient in, we get an MRI with a frame in place, we find that nerve just like you would in an open surgery, but now on a screen, and we focus that radiation right where that nerve is being hit, essentially. By treating with a certain amount of radiation, you don't kill the nerve, but what you do is you actually change the physiology of that nerve so that the pain goes away. So many patients will benefit from this. We have about an 80% success rate, okay, with first treatments. For those people who actually don't get well, there's about an 80% success rate with second treatments. Okay, so with radiosurgery and with medicines, we can often manage those elderly patients or patients who are averse to surgery for some reason or another, who have trigeminal neuralgia.
Sounds like good news, Judy, and that you have some treatment options. Thank you, doctor, and thank you, Judy, for calling, and we hope that helps for you and your mom. Let's go to line 6. Alan is next, calling us from Eastern New Orleans this evening. Alan, you're next. Go right ahead.
Thank you.
Go ahead, Alan.
Alan is next, calling us from Eastern New Orleans this evening. Alan? Yes, my name is Alan Stevens, and I'm calling from New Orleans Beach. I've had pituitary brain tumor, and I was treated about a year ago, and the tumor set on the optic nerve, and the doctor informed me that they would be able to take the pressure off the nerve, but he may not be able to get all of the tumor. And in essence, that's exactly what happened. They were able to take the pressure off of the optic nerve. Now, the doctor informed me that he did not get it all, but they would monitor it, and there would be treatment depending on how fast it grows or the condition, if it comes back. My concern is, if it does, the type of treatment be recommended, my quality of life after this treatment, and what type of treatment would be used.
Thank you, Alan. Some good questions for Dr. Ware.
That's an extremely good question. Pituitary tumors are, by and large, benign. And there are different types of pituitary adenomas. There are those that you can treat with medicines and those that you can't. And it sounds like the caller's one is one that cannot be treated or was not treated with medicines, but with surgery. With these tumors, they actually cause problems in humans because these tumors can get big, and because of their location, the pituitary fossa is located underneath the optic chiasm where the two nerves that subserve the eyes come together. As the tumor gets bigger, it can push on those, and that's what the caller was referring to. In many cases, these can get to be And so there are patients who come in with these large tumors.
And vision is going to be a primary symptom?
Vision is going to be a primary symptom. And because it happens fairly slowly in patients, they actually don't realize that they're losing vision. And it's vision in the periphery that's usually lost first. So what happens is their visual world narrows without them knowing it. Mm-hmm. Often people don't know that they have a problem until they start cutting someone off or they start bumping into people. Now, what the caller mentioned was that they were able to get a partial resection, meaning that they were able to take some of the tumor away and take the pressure off of the optic nerve. And in many cases, the nerve function returns after that, which is great news. But a lot of patients are left with, in the same condition that this patient is, where there's a residual tumor that has to be followed. Okay. Now, what are the treatments for that? So, in a case like this patient, where the nerve is decompressed, radiosurgery is also an excellent option. Okay. In addition to radiosurgery, one can have a conformal radiation therapy, where it's not the high dose radiation. You can give lower doses more frequently and have it in a fairly accurate area so that the optic nerves are not involved. So this is a patient who could benefit in the future from radiosurgery.
And the final part of Alan's question was quality of life after these sort of treatment options.
Right. So so the best thing about radiosurgery, especially in this area, is that there are few negative side effects. So most patients who, because it's non-invasive, most patients who have this surgery are able to return to their lives the day afterwards. They often don't have any complications of this. If they do, it's usually from swelling afterwards or from a change in the production of the pituitary hormones, which can be given basically by mouth. So essentially, you can actually have an excellent quality of life if this starts to grow again. However, the caveat here is that you have to have frequent checkups of this so that you don't end up in a situation where the tumor now has grown back up against the optic nerve or the optic chiasm.
All right. Alan, thank you for your question. Let's go to the North Shore in Slidell, where Edna is holding on line 3. Edna, you're on Hello Health with Dr. Marcus Ware.
Hi, I have a question. First of all, about 4 years ago, I had a slight stroke where I lost the left eye, and they had to go in there and pull the eye socket out and pinch the nerve back. I was lucky to get my eyesight back. But another question is, how can you tell if you have a, brain tumor or something? What are the symptoms? Mm-hmm. Because I suffer with a lot of migraine headaches, and I noticed that I'm losing some of my hair.
Okay, all right. So patients with brain tumors can present in a number of different ways. You mentioned that you have headaches, and a lot of patients who have brain tumors will present with headaches. Some of them can present with seizures, but you can also present with problems with vision, so on and so forth. The key here, though, is that if you have any of these symptoms, you see your physician and you get this worked up. If you have a tumor, you can come in and get an MRI. We'll take a very good look at that and see whether there's a mass there growing, or whether this is actually a stroke, which is quite different from a tumor.
And we don't mean to scare people tonight. There's lots of other reasons people get headaches that don't have anything to do with tumors.
The vast majority of people who have headaches essentially just have headaches. And one of the great things about that is that we have headache specialists that can treat those patients and focus on their problems.
Right. Edna, thank you very much for your call. We appreciate it. Our guest tonight is Dr. Marcus Ware, and we're talking about brain tumors. Let's go to line 2, where Darlene is holding this evening. Darlene calling us from Maymeet. Darlene, thanks for calling. You're on with Dr. Ware.
Dr. Ware, I have a daughter that has been diagnosed with a cancerous tumor. She just had a brain biopsy 3 weeks ago, and it is a starburst form of cancer, and she's fixing to go through surgery on April 1st. It's on the right temple lobe. And my question is what is going to be the results after they take 9 centimeters of this right temple lobe out? How is she going to be after that? And I have a name for the cancer if you need it.
If you do, it'd be very helpful.
She's in a severe pain in the stomach area, lots of nerve pain in the back and the stomach, and she's also a type 2 diabetic.
And what exactly is the name of the cancer again?
It's OLIGOASTROCYLOMA, and it is a grade 2.
Okay. All right. So grade 2. So grade 2 tumors are on the spectrum here. So for those types of tumors, this is an oligodendroglioma, is what she's describing. These are tumors that can either be grade 2, which is the lowest grade an oligodendroglioma is, up to grade 4. Okay, and so with a grade 2 lesion, one can have an excellent result after a surgery. Okay, the right temporal lobe is in most people, the right temporal lobe does not have a lot of functionality in it. So usually speech lives in the left temporal lobe. Usually most of your memory is locked in by structures in the left temporal lobe. And so for tumors in the right temporal lobe, you can usually resect more of that lobe and still maintain excellent function. Okay, so this is actually a case where a surgery can be very important in that it can, number one, ensure that this is truly the diagnosis. Okay, so you take the tissue, you have all of it there, your pathologist goes through it to be sure that that's what it is. For grade 2 tumors, okay, the usual treatment is to resect those tumors and then follow them. Okay, all right. And then if there's any change, you either go back and get more biopsies or radiation therapy. So this is a case where surgery is very important, okay? This is a case where it's actually in a place that is not relatively horrible to have.
If you're picking a spot and you have to have it, that's where you want it.
Well, it's not the ideal place, but it's actually fairly good compared to the contralateral side, okay? So this is something that I would be more hopeful than not about in a patient.
Okay. Our phone number is 504-866-3200. That's 504-866-3200. We do have some open phone lines, and we hope you'll call us with your questions about brain tumors tonight. Our guest is Dr. Marcus Ware. Well, many of you sent us email questions before the show even started, so let's get to some of those right now. Doctor, about 6 years ago, I fell and smashed my forehead into the concrete and started with severe headaches. After an MRI, I was diagnosed with a cyst on my brain stem. I was told that surgery would have about an 85% success ratio and opted to drink coffee as the caffeine alleviated most of the pain. Is there a non-invasive procedure without the bad outcomes that could cure this problem? This is from CJ. CJ, thank you for the question.
All right. So it sounds like this patient has what's called an arachnoid cyst. And an arachnoid cyst is essentially a membrane that forms and traps fluid within it, okay? And it acts like a one-way valve. So sometimes these get bigger but can't get smaller. And as they get bigger, they actually can put pressure on the brain. It sounds also like this gentleman has been having headaches, but most of his headaches are controlled with just caffeine, okay? So he may be a person who has headaches for other reasons and has this cyst. Now there are several types of procedures that can address this cyst. The simplest is a fenestration, meaning that if you can actually take this cyst and poke a big enough hole in it next to the normal CSF pathways, you can have the cyst drain on its own, okay? Now the concern with that is that if you poke a hole in it in some way or another, that it may reseal, okay? So, you know, not looking at the films right now, not looking at the images, I would say that there are two options. One is you can have an open craniotomy where we take off a larger window of bone, but maybe since he's been seen there have been newer things that are out there. So we now do minimally invasive craniotomies where the incisions are small. The corridors that we use to get to the cyst are very small, and patients recover much better from those. So there isn't necessarily a non-invasive treatment that may be helpful, but there are lesser invasive procedures that are available now, and I would actually encourage them to seek those out.
All right, thanks for your question. Let's go to Amit again, it looks like. Is that Kathy who's calling us? No, let's go to line 1. Raymond is next. Let's go to Raymond on line 1 if we can, calling us from New Orleans. Kathy, if you're there, we'll get back to you in just a moment. Let's go to line 1. Raymond, you're next with Dr. Marcus Ware. Go right ahead.
Yeah. Good night. Very interesting show. I'd like to know what type of brain tumor did Johnny Cochran have, and why couldn't he be cured, and why those cancers so dangerous and uncurable? Thank you.
For those who don't remember, maybe too young, Johnny Cochran, the attorney for O.J. Simpson, very prominent and well-known attorney.
Yeah, so Johnny Cochran actually had a tumor called a glioblastoma multiforme. And that is one of these grade 4 tumors that I mentioned before. And so with these tumors, they're difficult to treat because they're, number one, fast growing, okay? And so so when these patients present, they often have a fairly sizable mass that's in their brain. In addition to that, these tumors actually are very good in sending out cells away from that. So you have, in addition to the tumor itself, you have malignant cells that have migrated away from the mass in and of itself, okay? So, such that when you actually go in and remove one of those tumors, you've removed the mass, and the patients may get better for a period of time and may feel better, but they will recur, okay? So those patients are then treated with radiation therapy and chemotherapy, okay? And even though they're treated with radiation therapy and chemotherapy, about 20% of those patients will progress through the radiation therapy. A fair fraction of those patients will progress fairly early after chemotherapy, okay? So the answer to that is, even with the best treatment, Johnny Cochran didn't survive because after he had had his surgery, his tumor recurred. They treated him with the options that were available, and despite that, his tumor grew. Senator Kennedy had the same type of tumor. There are a lot of other people who have this. This is actually the most common type of primary tumor, is this glioblastoma. The most common type of primary malignant tumors is glioblastoma multiforme. In fact, it makes up more than 50% of those.
What does best practices tell us about pre-screening? So I don't have any symptoms, but I hear enough about this. I watch the program on television, and I just want to make sure there's no tumor development happening there. And body scans are, people are already getting body scans. Do you recommend that for the brain yet?
Not quite for everyone. And I'll tell you why. The reason is that even though these primary tumors, when they do occur, are horrible, they aren't so frequently seen. So for instance, this glioblastoma multiforme, there'll be somewhere between 16 and 17,000 cases diagnosed in the U.S. next year. Okay, so that means that if you have a headache, there's very low likelihood of you having one of these. Okay, on the other hand, if you have lung cancer and you get a headache, okay, then you need to see your physician and be screened. One might even say if you're a heavy smoker and you've smoked for a long time and you have any neurological symptoms at all, I would be screened. So I wouldn't apply that to the entire population.
Right.
But if you have a personal history of cancer, even if you believe that there was a cure, we see patients all the time who had renal cell carcinoma that was treated 5 years ago, and now they present with a solitary metastasis to the brain. So if you have a personal history of cancer and you have any symptoms that are concerning, then I think it's a good idea to be screened.
All right. Let's go back to the phone lines. Kathy, I appreciate your patience. Kathy calling us from Amit this evening. Kathy, go right ahead.
Yes, sir. My question is, well, first of all, I have been diagnosed with two pituitary tumors a few years ago, and I haven't had any problems with it, but and a few months ago, all of a sudden, my left side of my face is just really, really swollen. It stays swollen. It's hard, real firm. And my right side is just normal, but yet I got all of a sudden, I come out with a little lump. It's like an egg. It looks like an egg, and it's hard. But nothing hurts or anything, but it just looks odd. And I'm just concerned about that a little bit. What do you think?
Okay. So I want to make sure I understand you. So you have a history of a pituitary tumor. You said two pituitary tumors, and that you've had those treated, correct?
Well, they haven't did anything. They just give me an MRI once a year to make sure they're not growing, and they're not growing.
Okay.
As far as I know.
So they're just following these, and in that setting, you have is it numbness or some hardness you say to your face or swelling?
It's just swelling. It stays swollen. It's like a hard knot. It's just weird. It looks like that one side of my face is just really round and big. And then my right side of my face is normal, but I have like an egg lump that came on it a few months ago.
My advice to you would be to really see your physician, your primary care physician, as quickly as you can. I'm not as concerned about the pituitary tumors, but anytime there's asymmetry to your face and you develop lumps in the face, that could be a number of things. It could be a lymph node. It could be a lymph node, which is essentially where your immune system is trying to rev up because something is abnormal in that area. That could be either an infection, okay, which is fairly common, or it could be a mass, like a neoplasm, a tumor of some type. So what I would recommend is anytime something like that happens, especially in an adult and it's persistent, to get in and see your doctor and have them take a look at it.
Okay. Thank you very much, Kathy, and good luck to you. We're going to, Doctor, we've got just a couple of minutes left and quite a few emails, so we're going to get to these as quickly as we can. I'm 85 years old, diagnosed with a benign neuroma in the auditory canal. I had CyberKnife in 2012. It did not remove the tumor completely, but it did reduce it in size. I do have occasional headaches, jaw pain on that side, and have difficulty with balance. In your experience, given my age, is this something that I should have surgery to remove the tumor completely? Do you find these tumors continuing to grow? I would appreciate your thoughts.
Okay. So essentially what you're talking about is an acoustic neuroma. It is a benign tumor that actually grows on the vestibular nerve, and so that can actually give you problems with your balance. These are benign tumors. The role of the treatment that she received was to arrest its growth. And it seems like that the CyberKnife has essentially done what it can do. And so the real question is, would doing a surgery improve your balance? And the answer to that is it most probably will not, okay? So my advice is that if you're doing well otherwise, I would just continue to follow this. There are certain risks to these surgeries, and especially after you get to a certain age, it doesn't necessarily make sense to take that risk for a little gain, okay? It's not going to, that tumor is not going to grow as long as they're looking at it. There are other treatments that are available. I would not necessarily recommend surgery.
Okay, thank you, doctor. Another email. I'm a patient of yours suffering from brain, back, and spinal cord tumors with suspected neurofibromatosis type 2. Any medicines for these treatment of these types of tumors? I've heard the drug Avastin may be effective. This is from Charles. Charles, thank you for your question.
So Avastin is the drug. Avastin is a drug that is usually used to treat malignant tumors. And what Avastin does is it stops the body's ability to make new vessels. So when a tumor is formed, it actually recruits new vessels in order to grow, okay? So Avastin is very useful for malignant tumors. It's useful for gliomas. And in F2, it's never shown to be useful, okay? So everything has its risks, and Avastin carries with it a bleeding risk because it essentially stops you from making new vessels. And some of the mechanisms involved in vessel repair and making new vessels are the same. So, so I would not necessarily recommend a drug that has risks if there's not a clear benefit. So the short answer is I wouldn't necessarily recommend it.
Okay. Charles, thank you. One more email, doctor. I've read there's been a correlation between consumption of artificial sweeteners, particular aspartame, as a cause of brain tumors. Is there a correlation? And if so, at what amount of intake should we be concerned about? This is from Tavis. Tavis, thank you for your question.
Mm-hmm. So that comes from studies in mice and rats where essentially they're looking for they're looking to see if substances that are around us can cause cancer. And so to do that, you actually take a mouse or a rat and you give them huge amounts of this. Okay. So the real problem is that, yes, we know that in a mouse model or a rat model, a large amount of aspartame can actually cause or lead to those animals developing tumors. The problem is that it's really impossible to then come back and dissect back and say what is a reasonable amount of this that one can have. Okay, and so that is essentially a problem that we don't have the solution to right now. So we know that it can be associated with it, and that's why you'll see warnings on the label, but no one can really tell you what's a safe dose.
All right, so going back to your original thought about what would I tell my mom? If your mom's using aspartame in her coffee and she's having a cup of coffee or two a day, you telling her to stop using it?
No, I don't. I would say I would just let her know that, you know, that this is what the studies have shown. There's certain drugs where if they don't reach a certain threshold, they don't cause problems. I wouldn't steer away from it.
All right, and very, very quickly, because I promised people I would do this, but very, very quickly, 30 seconds or less, do you think there'll be a day where we can prevent brain tumors?
I do. I do think that, that there will be a day. What we see now is that the systemic treatment of other cancers have really improved. With those systemic treatments, we're seeing more brain tumors, probably because patients are living longer. And, you know, that's not a bad problem to have, okay? However, now it leaves us with the challenge of treating the brain tumor, okay? Just like we've had better systemic treatments, I think that we're going to develop better treatments for the brain. The NIH has made that a major initiative. It used to be that if you had a brain tumor, you couldn't get in a clinical trial. Right now, the NIH is funding trials to treat brain tumors. So there's been an about face, okay? And so that's why I say it's a very exciting time to treat these tumors, and I think we're going to make some headway over the next 20 to 30 years.
Let's certainly hope so. Dr. Marcus Ware, thank you so much.
All right,
appreciate you being with us tonight. Well, as a reminder, you can rewatch tonight's presentation or any of our Hello Health programs by going to our website. That's at www.wlae.com or on Ochsner's website at ochsner.org. Just type Hello Health in the search areas. Our thanks again to tonight's guest, Dr. Marcus Ware. Thanks to Humana and Ochsner for making this program possible. And our final thanks, as always, is to you for your support of our program, Hello Health, and our station, WLAE. Good evening.
Hello Health on LAE has been presented by the Ochsner Health System. 850 physicians and 90 medical specialties working with a team of more than 13,000 employees provide nationally recognized health care across Southeast Louisiana. Ochsner, health care with peace of mind.
I call it my one less thing to worry about plan. With a Humana Medicare Advantage health plan, I get more clear information about my options with 24-hour access to my Humana, my secure website, and I can get help every step of the way from a Humana Market Point representative.
More of what you want, because you deserve more.